Hi everyone, and welcome to our module on congenital heart disease. So before we talk about specific congenital heart defects, let's talk about cyanosis. Cyanosis means a blue discoloration of the skin due to low oxygen delivery to the tissues, and there are two types of cyanosis that you should be aware of. Central cyanosis is the type that occurs in babies with congenital heart defects. These babies have a normal cardiac output and the blood is flowing fine. There just isn't enough oxygen in the bloodstream, usually because the blood is bypassing the lungs. So these children will have blue lips, blue nail beds, the conjunctiva, the eyes can be blue, but they will have warm extremities because the blood is flowing fine to their hands and feet. The other type of cyanosis is peripheral cyanosis, and this occurs when there is low blood flow. So for example, patients who have severe heart failure will get blue fingertips and toes because they just are not pumping enough blood to those distal portions of their body. They will have cold extremities, and you can actually see peripheral cyanosis on yourself if your hands are out in the cold for a long period of time. But this is very different from the central cyanosis that we're talking about in children with congenital heart defects. So blue babies are babies that are born with cyanotic congenital heart defects, and they will show evidence of cyanosis very early in life, sometimes right after birth. And this occurs when there's a heart defect that causes blood to bypass the lungs and causes deoxygenated blood to circulate to the body. And there are 5 conditions that cause this, and they're called the 5 terrible T's: tetralogy of Fallot, transposition of the great vessels, truncus arteriosus, tricuspid atresia, and total anomalous pulmonary venous return. And we'll talk about all of these in this module now. So let's begin by talking about tetralogy of Fallot. Tetralogy of Fallot is a constellation of 4 findings, and that's why it's called a tetralogy, and it's named after Fallot, the physician in the 1800s from France who first described it. So the 4 components of a tetralogy of Fallot are: first, a VSD, and there's a drawing over here which shows the connection between the right ventricle and the left ventricle here that represents the VSD. There's hypertrophy of the right ventricle, so this right ventricle in the drawing is very thick, and that's because it's working extra hard in this condition. There is an overriding aorta, which means the aorta has moved this way and pushed the pulmonary artery a little bit over towards the right ventricle. And then finally, there is pulmonary stenosis, which is this thickening of the pulmonic valve right here that blocks flow of blood going to the lungs. So essentially, I think of tetralogy of Fallot as a VSD of the worst kind you can possibly have, because blood is being pushed away from the RV outflow tract and through the VSD by the rest of the problems in this congenital anomaly. So because there's pulmonic stenosis, it's very difficult for the right ventricle to push blood into the pulmonary artery and to the lungs. So blood is preferentially diverted across the VSD and over to the left side of the heart, and therefore the blood bypasses the lungs, and the baby will have evidence of cyanosis because deoxygenated blood is being circulated through the body. This problem occurs when neural crest cells in the developing embryo fail to migrate. So the heart inflow and outflow tracts come from a tube in the embryo, and the tube folds and separates. There's a step in this process where the primitive truncus arteriosus and bulbus cordis divide into the aorta and pulmonary artery. For this step to happen, neural crest cells, which are very important cells, have to migrate and separate the aorta from the pulmonary artery. Failure of this process causes tetralogy of Fallot. It also contributes to truncus arteriosus and transposition of the great vessels, which we'll talk about later. So children who have this condition have some peculiar symptoms and physiology you need to know about. So when children with this condition squat, it makes them feel better. So why does that happen? When they squat, they kink their femoral arteries, and this increases the afterload. This makes it harder for blood to leave the left ventricle, and therefore it diverts blood across the VSD back to the right ventricle and into the lungs. So when children squat with tetralogy of Fallot, they feel better. Children with tetralogy of Fallot also get these episodes called tet spells, where they suddenly become cyanotic when agitated. We don't really understand exactly what triggers them, but the child will get worked up and become very cyanotic, and they can actually have complete RVOT obstruction during these tet spells and get very, very sick. These spells are treated by giving the child oxygen, putting their knees to their chest, again to kink the femoral artery so that more blood goes to the lungs. And they're sometimes administered non-selective beta blockers like propranolol, which relax the RVOT and let more blood flow go to the lungs. Next condition we'll talk about is truncus arteriosus. In this condition, you have a common arterial trunk. So I've drawn this over here. Instead of a pulmonary artery and an aorta, there's just one single trunk. And that is very bad because it means blood is being pumped into a common trunk, and some may go to the lungs, but some may go to the arterial system. It's a very inefficient circulatory system, and the patient will get cyanotic. This almost always has a VSD, and the mixing of blood is what's responsible for the cyanosis. This is also a problem with neural crest cell migration in the developing embryo. Next condition is transposition of the great vessels. So in this problem, the aorta and pulmonary artery are attached to the wrong side. So normally the aorta attaches to the left ventricle, but in this condition it's attached to the right ventricle. And normally the pulmonary artery attaches to the RV, but in this condition it's attached to the LV. So the right ventricle pumps blood to the aorta, to the body, back to the RA, back to the RV. Blood goes through this whole circuit and never enters the lungs. The left side pumps blood to the pulmonary artery, through the lungs and back to the LA, and then to the LV again. You have two completely separate circuits. And this is not going to be compatible with survival unless there's a shunt present like a PADA or VSD so that the two separate circuits can mix. Very high yield to know that this is associated with maternal diabetes. It's a failure of the aorticopulmonary septum to spiral, which also involves the neural crest cells. And a little pearl about how this condition is sometimes managed. Babies with transposition will be given a prostadil, which maintains patency of the ductus arteriosus, and this will help maintain the shunt until there can be a definitive surgical repair. And we'll talk more about this when we talk about PDAs. Next condition is tricuspid atresia. So in this condition, there is no tricuspid valve. So over here in this drawing, I've shown you there is no valve for blood to cross to go from the RA to the RV. Since there's no communication between the RA and the RV, blood goes from the RA to the LA via PFO or ASD. If it wants to get to the lungs, it has to go down into the LV, cross over to the RV, and go up here to the lungs. There's also some blood to the lungs from the aorta to the pulmonary artery via the PDA. But regardless, this is a very inefficient system, and a lot of deoxygenated blood circulates through the body, and therefore the baby or child will have evidence of cyanosis. The final terrible T is total anomalous pulmonary venous return. So remember that the pulmonary veins drain blood from the lungs to the left atrium, but in this condition they drain to the venous system, either to the right atrium or to one of the structures feeding the right atrium. The physiology is the same as having a shunt from the left atrium to the right atrium, but having a very severe shunt because all the blood goes through it. The right atrium and the RV will dilate, and you'll get mixed low oxygen blood going to the body through an ASD or a PDA. So now let's talk about blue kids. The 5 T's cause blue babies, but blue kids are children who are born with a heart defect that doesn't cause cyanosis until later in life. So what happens to cause cyanosis in these conditions is that blood goes through the lungs but then leaks back to the right ventricle. Initially, this will be tolerated by the body. The right ventricle will just work harder. But as time goes on, the right ventricle can hypertrophy and start pumping blood from the right side of the heart to the left side of the heart. That's called Eisenmenger syndrome, and we'll talk a little bit more about that in a minute. I've placed a drawing on the slide to help you better understand the physiology of these shunts. So an ASD, or atrial septal defect, is a communication between the left atrium and the right atrium. A VSD, or ventricular septal defect, is a communication between the left ventricle and the right ventricle. And finally, a patent ductus arteriosus, or PDA, is a communication between the aorta and the pulmonary artery. Now, under normal circumstances, the pressures are always higher on the left side of the heart than the right side of the heart. So under normal circumstances, the left atrial pressure is higher than the right atrial pressure, the left ventricular pressure is higher than the right ventricular pressure, and aortic pressure is higher than pulmonary artery pressure. What this means is that initially in children born with any of these 3 types of shunts, blood will flow from the left side to the right side of the heart. In other words, blood will be normally oxygenated, however, some of it will leak backwards from the left side of the heart to the right side of the heart. But this won't cause cyanosis because blood is still flowing normally through the lungs to the left side of the heart and out to the body. With time, however, a very important change is going to occur. When one of these shunts is present, the chronic overloaded state of the right side of the heart, including the right atrium, right ventricle, and pulmonary artery, will lead to increased pulmonary vascular resistance. And this is the thing you want to remember for step 1. That chronic overload of the right side of the heart damages the pulmonary vasculature, and as a result, the pulmonary vascular resistance rises and pulmonary hypertension will develop. When the pressures on the right side of the heart and in the lungs get high enough, these shunts will reverse. So instead of flowing from left to right, many years after one of these shunts is present, you will get flow from right to left. So for example, from the right atrium to the left atrium across an ASD, or from the RV to the LV across a VSD, or from the PA to the aorta across a PDA. When the shunt reverses, that's called Eisenmenger syndrome, and in that situation, blood will begin to bypass the lungs and the child will develop cyanosis. This takes many years to occur, and that's why children born with these shunts, if they're left untreated, develop cyanosis, but not until an older age. So the first condition we'll talk about is a ventricular septal defect, and it's high yield to know that this is the most common congenital anomaly. It's also high yield to know it's associated with fetal alcohol syndrome. This is a communication between the LV and the RV, and it causes a harsh holosystolic murmur that's heard best in the left lower sternal border. If VSDs are very large, they can cause symptoms early in life from the overload of the right side of the heart. The baby can have signs of right-sided heart failure. However, if they're small, they may not cause symptoms until later in life when the right ventricle hypertrophies and shifts blood from the right side to the left side. And then if they're very small, they may never cause symptoms, but the child may have a murmur throughout its life. ASDs are communications between the LA and the RA, and the oscillatory finding of an ASD is a wide fixed split of the S2. The most common type is a secundum type, which occurs right here, sort of in the middle of the intraatrial septum. However, another type that you should know about is called primum, and this is associated with Down syndrome. These ones occur much lower down in the septum, close to the portion where the valves insert and close to the ventricular septum. There are very important embryologic structures called endocardial cushions, and if they are defective, they will cause endocardial cushion defects, which include a primum type ASD, as well as a ventricular septal defect down in this portion of the ventricle, all sort of centrally located in here, near where the atrial septum meets the ventricular septum. When ASDs are detected on children or even in young adults, we often follow them without surgery if they're small. However, if they're significantly large, we will offer surgery to prevent future problems, because over time the ASD can lead to pulmonary hypertension. The chronic overload of the right ventricle chronically overloads the lungs, and the pulmonary arteries will hypertrophy and thicken, and pulmonary hypertension can develop. So if ASDs are discovered that are sufficiently big, we'll recommend a surgery.
Next, let's talk about a patent ductus arteriosus, or PDA. Recall that the ductus arteriosus is a vascular structure that shunts blood in utero from the left pulmonary artery to the aorta, therefore bypassing the lungs. And it should close after birth, and the reason it should close after birth is because its patency in utero is maintained by high levels of prostaglandin, especially prostaglandin E2, and at birth the levels of prostaglandin in the newborn baby fall dramatically compared to in utero. There are a number of sources of prostaglandins in utero, but an important one is the placenta. So when the placenta is removed at birth, levels of prostaglandins, including prostaglandin E2, fall, and this should close the ductus arteriosus. However, if it does not close, that results in formation of a patent ductus arteriosus, or a PDA. There are two drugs that are sometimes administered to newborn babies to manipulate the ductus arteriosus. The first one is indomethacin, which is an NSAID. This is sometimes given to close PDAs. Indomethacin will blunt the synthesis of prostaglandins in the newborn baby, and that will lower prostaglandin levels even further and hopefully close a patent ductus arteriosus. Another drug sometimes given to newborn babies is alprostadil. Alprostadil is an analog of prostaglandin E1, but it has similar effects to prostaglandin E2 in the newborn baby, and it will keep the ductus arteriosus open, and this is sometimes necessary in certain forms of congenital heart disease where that PDA is an important conduit to deliver blood if other vascular structures are not formed correctly.
The murmur of a PDA is a continuous murmur, and that makes it pretty exceptional because most murmurs are systolic or diastolic, but PDAs are heard throughout the cardiac cycle, and it's described as a machine-like murmur. This problem is associated with congenital rubella syndrome, which is something very rare in developed countries, so you should think about it in babies who are from mothers who are immigrants. And one of the classic findings of a patent ductus arteriosus is what's called differential cyanosis. So the baby or the child will have blue toes but normal fingers. So why does this happen? Well, oxygenated blood that has gone through the lungs will pump from the left ventricle and reach the upper extremities, giving the baby normal fingers and upper extremity findings. However, deoxygenated blood will cross the patent ductus arteriosus to the aorta and go down to the toes and make the toes blue. And this would only occur after the shunt has reversed and become right to left, but you can see this differential cyanosis in a PDA. You can also see a wide pulse pressure in a PDA. Why does this happen? Well, normally the pressure in the aorta goes up to about 120 and comes down to about 80, and it goes through this cycle. But when there's a PDA, it drops very, very low because there's an extra way for blood to leak out of the arterial tree. That makes for a low diastolic pressure, and therefore the difference between the peak and the trough, the difference between systolic and diastolic, will be greater, and that's what's called the pulse pressure. Indications for closure when a PDA is detected are first pulmonary hypertension. If we find evidence of that, we know that the lungs are being overloaded and we want to close the shunt. There's also a peculiar problem with PDAs, which is they sometimes develop bacterial vegetations. This is called endarteritis. So usually on the pulmonary side, there will be evidence of vegetation, much like what's seen in endocarditis, and this can cause embolisms to the lungs. So if we see that, we will recommend closure of the PDA. For PDAs that are small and asymptomatic or silent, it's not really clear. I have seen a few patients like this, and usually if their exercise tolerance is fine and their heart is normal, these can be followed over time without any surgical intervention. So Eisenmenger syndrome is when a shunt through an ASD, VSD, or PDA reverses to start becoming right to left instead of left to right. This is what we've been talking about in previous slides. Chronic overload of the right heart leads to RV hypertrophy and pulmonary hypertension, and the shunt reverses. Now the patient will develop cyanosis. They can get clubbing of their fingers, which is a finding due to chronic hypoxia. And then a very important finding of Eisenmenger syndrome is polycythemia. The chronic hypoxia induces the body to synthesize more red blood cells. So these patients can have very high crits in the 50s or 60s. And then you will see right ventricular hypertrophy when you look at the right heart by an echocardiogram. Now let's talk about a condition that's very rare in actual practice but is very, very high yield for the boards, and that is coarctation of the aorta. So I've drawn an aorta here with a coarctation, and you can see that after the subclavian artery takeoff, it narrows down to a point here and then it widens out after that, and that's called a coarctation, and that is going to have some very important physiologic effects on the body that you need to know about. Coarctations are described as either postductal or preductal depending on their relationship to the ductus arteriosus. So a postductal coarctation is the type I've drawn in this picture here. The ductus arteriosus comes in here right after the subclavian artery takes off, and then you have the coarctation. This is the type that's called adult type because it's sometimes not discovered until the patient becomes an adult, and there's no cyanosis associated with this. The other type is called the preductal type, and that would be where the coarctation occurs before the ductus arteriosus. So for example, if the ductus arteriosus were right here as I've drawn, the coarctation occurs before it. This is called the infantile type, and this type has cyanosis in the toes. And let's talk a little bit about why these two types have different physiology. Let's first talk about the preductal type of coarctation. So in this type of coarctation, the aorta narrows to a beak, sort of like an hourglass here, and then the ductus arteriosus enters after the coarctation. Because of this coarctation, there will be a pressure gradient across the coarct, and there will be low pressure beyond the coarctation because a lot of pressure will be expended getting blood across this obstruction. Because of the low blood pressure distal to the coarctation, blood will cross the ductus arteriosus and bypass the lungs and get delivered to the lower extremities. So these babies can have cyanosis of their toes, which is called differential cyanosis. The upper extremities will get blood from the left ventricle that has gone through the lungs in the normal way. A serious problem with this type of coarctation is that once the ductus arteriosus closes, if this coarctation is very severe, the afterload on the heart will abruptly rise significantly. The ductus arteriosus actually offloads a lot of blood from the heart by diverting it beyond the coarctation. Once it closes, all that blood has to go through the heart and then get past this coarctation. As a result, you get a big increase in afterload. The baby can suddenly have a rise in LVEDP and develop acute heart failure. The left ventricle can even dilate and fail and cause shock. And this is the type of coarctation that is associated with Turner syndrome. In the adult type of coarctation, the coarctation occurs after the ductus arteriosus, and usually the ductus arteriosus closes, but these types of coarctations are usually not so severe that they cause the left ventricle to fail. The main effect of this type of coarctation is that there will be low blood pressure in the lower extremities because the coarc looks like that hourglass again, and so you'll have high pressure up here as the body tries to push blood beyond the coarctation after the coarctation, there will be very low blood pressure because there's a pressure drop across the lesion. Since the lower extremities see low blood pressure, they will respond accordingly. The kidneys will release renin and the sympathetic nervous system will get stimulated. The result is that the upper extremities and head will have high blood pressure. RAA symptom has been ramped up, sympathetic system is activated. These are often treated with surgery, and this is the type of coarctation that's associated with a bicuspid aortic valve. For patients with this adult type of coarctation, the only sign and symptom may be hypertension in the arms, and it is one of the very rare causes of secondary hypertension. There's sometimes a murmur over the back between the scapula, and this is a very unusual place to ever hear a murmur. And in addition, it is a continuous murmur, and most murmurs are systolic or diastolic, so this would be an unusual location of a continuous murmur with a coarctation. There can be weak pulses in the femoral arteries, but strong pulses in the upper extremities. Patients with this type of coarctation can have pain with walking. That's called claudication. And this is because the blood pressure is so low in their legs that when they walk, they don't get enough blood flow. Rarely, these patients can also have headache, and the chronic high pressure over time can lead to heart failure. Some more signs and symptoms of coarctation you should know about. An X-ray may show what's called rib notching. So there's high pressure above the coarctation, and this forces blood into the intercostal arteries, which enlarge to carry blood around the obstruction. The intercostal arteries bulge into the rib, and you will see rib notching on X-ray. Another classic chest X-ray finding of coarctation is called the 3 sign, because there is a bulge before the coarctation and then after the coarctation. So the vessel might look like this. You would see down the side what looks like the number 3 here, and that's called the 3 sign on chest X-ray. Let's talk about the physiology, because this is heavily tested on the board exams. So the body is going to compensate to try and maintain blood flow in the lower extremities despite the fact that the pressure is low down there from the coarc. In the upper extremities, there will be very high blood pressure as the body works to push blood across that coarctation. This is going to create high flow to the organs and structures in the upper extremities. You may think that when there's high pressure, the arterioles vasodilate to decrease the pressure, but here there is a different phenomena going on. The arterioles are actually going to constrict to try and limit the blood flow to the normal level. This is a local effect not mediated by the sympathetic or parasympathetic system. There is such high pressure in the upper extremities that the organs and structures call for vasoconstriction to limit the blood flow. They are getting more oxygen than they need because that high pressure is causing high blood flow, so they are constricting to shut down the oxygen delivery. As a result, the resistance to flow is very high in the upper extremities, and it's high yield to know that. In the lower extremities, you have low blood pressure. Therefore, there is low blood flow to those organs. So those arterioles are dilating to try and get the flow to increase. Remember, blood flow is equal to pressure over resistance. So these organs want to lower the resistance in the lower extremities to try and increase the blood flow. The result is that you get normal or compensated flow in the lower extremities. Some more physiology of coarctations. The low pressure at the level of the kidneys activates the renin system, the body retains salt and water, and there's increased total peripheral resistance. You often get upper hypertension with lower extremity normal blood pressure, especially when the coarctation has compensated. The baroreceptors in the body are very confused. The upper extremity carotid sinus is seeing high blood pressure, and it's trying to shut down the sympathetic system and increase the parasympathetic. However, this is being battled by the response from the lower extremities, where the kidneys are secreting renin and activating the angiotensin system. Okay, let's move on to a patent foramen ovale. So this is found in about 1 of every 4 adults. It is a very common finding in adult hearts. It's failure of the foramen ovale to close after birth. By and large, this has no clinical impact for the patient. The only exception is that in theory, the PFO can allow a blood clot from the femoral veins to cross to the left side of the body and cause a stroke. The frequency with which this happens is hotly debated, and clinical studies of closing PFOs to try and prevent strokes have been disappointing. So it's not clear how much PFOs actually play a role in strokes. But nevertheless, for board questions, you should look for stroke symptoms in a patient with a history for DVT and PE, and know that that patient may have a patent foramen ovale with clot crossing to the left side. Let's briefly mention pulmonary atresia. This is a very serious and rare congenital heart defect where the pulmonic valve orifice doesn't develop. So basically there is no pulmonic valve that can open, and there's no flow from the right ventricle to the lungs. This is okay in uterus because the baby gets oxygen from the mother, but after birth, when it needs to pump blood through the lungs, big problems develop. Usually these babies have a VSD for outflow of the right ventricle, and the survival depends on the ductus arteriosus to allow blood to cross from the arterial system them to the pulmonary artery and get to the lungs. A prostadil is sometimes used to keep the ductus arteriosus in these babies open until definitive surgical correction can be done. And finally, we'll talk about Ebstein's anomaly. So Ebstein's anomaly is apical displacement of the tricuspid valve. So I've drawn a normal heart over here, but in Ebstein's anomaly, the tricuspid valve, instead of being up here, is way down here inside the right ventricle. And you get what's called atrialization of this tissue above the tricuspid valve. The real problem with this physiologically is severe tricuspid regurgitation, which leads to heart failure. You can sometimes get cyanosis if there's an ASD or PFO because the pressures can get so high on the right side of the heart that Eisenmenger syndrome develops and blood crosses over to the left side without going through the lungs. And this has two important associations. Maternal lithium intake is associated with Ebstein's anomaly, and then the WPW syndrome is strongly associated with this condition. Patients with Ebstein anomaly have a high frequency of bypass tracks. And that concludes our module on congenital heart disease.